Hello, Insta family. It's Dr. T here on the couch. Tonight we are going to talk about all things fertility. And I've had a bucket load of questions. So I've tried to put a few of them together. If you do have any burning last minute questions that you want to add in, just dump it into the chat. And hopefully I'll catch them as they roll on through and I might be able to add them to the end. But yeah, heaps of questions because this is our favourite topic, right? Who's loving this topic? Make sure that you tag your mates in because I want to be able to share this with as many people as I can. Now I want to remind everybody that the information that I share on here is general information. Mostly evidence-based. If there's no evidence, it will be a little bit evidence-based, but mostly evidence-based. And if you have something that is pertaining to you, then make sure that you go and see your doctor, go and see your fertility specialist, go and see anybody who can help to find the answers to your questions and help you achieve the goal that you're looking for. But today, we're talking about all things fertility. And I'm super excited too, because next Wednesday night, I'm going to be talking about after the embryo transfer. I asked a question. I'm hoping you guys saw it on a previous feed. I also asked it over on Facebook as well. To those of you who've had an embryo transfer, you're lined up for an embryo transfer, you might be doing an embryo transfer in the future. Once you've had that transfer, your pants are back on. What are the burning questions that you want to ask the doctor, the embryologist, the nurse while you've got them there? And hopefully we'll be able to answer some of those questions. So that's going to be Wednesday night. But today, general fertility questions. So thank you to those of you who have dropped some questions my way. And thank you so much for tuning in. And don't forget to tag others. If you find this information really helpful and you know someone that's going to benefit from this, please tag them into this Instagram live. All right, so the first question, what is the likelihood of falling pregnant after being treated for Ashman's? Ooh, Ashman's. Does the likelihood of falling pregnant decrease to less than before, or does it return? Okay, so let's talk about what Ashman's is. Ashman's is scar tissue that has developed on the inner cavity of the uterus. Obviously, that is where the little embryo likes to implant. And scar tissue is bad. It's bad because it stops the endometrium from growing, but it can also prevent implantation. So Ashman's occurs due to some sort of trauma. It might have been previous infection, it might have been retained products, it might have been from a surgical procedure, a D&C for example. Some women who've had myomectomies or fibroids taken out of their uterus, sometimes if you breach into the cavity, that can set up scar tissue. Scar tissue is bad for implantation. How do we often diagnose it? Well, it's often diagnosed when we do procedures to check tubal patency, so what we call an HSG. Sometimes we go looking for Ashman's if someone presents with having had, say, a procedure and then gets really light or even absent periods. And we do a procedure, a hysteroscopy, or even imaging, a saline sonohystogram, and it shows up that there is scar tissue on the inner cavity. Now, the gold standard is actually a hysteroscopy if you go in with a camera and you actually see scar tissue across the cavity. There are various stages of Ashman's, from mild, just some filmy adhesions in some part of the cavity, right through to major Ashman's where the cavities can be even completely obliterated. The only management for Ashman's syndrome is surgical and really should be done by a surgeon with experience in managing Ashman's. So you want to be managed by a surgeon or a centre of excellence in this area, someone with experience. Now, as far as the impact on fertility, we know that even with treatment, your chances of falling pregnant after Ashman's is inversely correlated. Let me see. I've got inversely correlated with the severity of your Ashman's. So if your Ashman's is mild, if your surgeon or your doctor has classified your Ashman's as mild, your chance of conceiving after having surgical treatment is somewhere around 70 to 80%. If you've got severe Ashman's, then your chances of conceiving even after surgical treatment is probably less than 20%. Most people do not go back to the equivalent level of fertility that they had before they developed Ashman syndrome. So unfortunately, it is one of those conditions that can be quite impactful, and there is a subset of women who may require surrogacy. Their Ashman's is so bad, they may require surrogacy. Can you fall pregnant after having surgical treatment with Ashman's? Absolutely, you can. But it is important to understand that it does have a significant effect on implantation. All right. Someone else has asked a very similar question. What can be done for a woman with uterine polyps, fibroids, has had them removed lots of different times, then has had multiple transfers without success? So we call that recurrent implantation failure. Okay, this is a massive question. But I think in my practice, I would always stop and check myself after, let's say, 3 or more transfers of good quality. How you measure quality, that's a whole nother discussion, but good quality embryos and no conception. So most of us would agree that transferring about 3 embryos and no pregnancy is probably still within the realms of normal. Once you get to the point where you've transferred more than 3, these are single embryo transfers, of course. Once you get to that point and there's no conception, no positive pregnancy test, you do start to check yourself, or you should start to check yourself and say, could this be the reason that this couple are not conceiving? Is this an embryo quality issue, or is this an endometrial receptivity issue? Now, in about 1/3 of cases, it'll be the embryo. In about 2/3 of cases, it will be the endometrium. So I would always go back to, all right, what's the largest group? Well, we know chromosomal abnormalities in the fetus are the largest group of things that lead to transfer of embryos without pregnancy. Beyond that, you do start to think of the anatomical things. Are there polyps? Are there fibroids? Has Ashman's developed because of surgical treatment of fibroids and polyps? Is there a septum? Is there a funny shape to the uterus? Then the next big area would be things about, sorry, a message has just come down. I get really distracted when messages, sorry, I just went off track. Then the next biggest group would be the endocrine things. So what's the prolactin doing? What's the thyroid function doing? How's their insulin resistance? What their weight doing? What's that metabolic environment like? Then I would look at things like clotting abnormalities, particularly the heritable ones, the ones that we test for. Then I would be looking at, the big cauldron where the witchcraftery happens, the immune factors. So when we go looking at things like natural killer cells and endometrial receptivity assays and all these funky things that you might find being offered by various different practitioners. Then there's the lifestyle things, the coffee, the alcohol, the lifestyle, the smoking, the DNA fragmentation of sperm. Then you're starting to get into stuff that doesn't have so much evidence there. But I would certainly check myself, and I would go back to looking at each of those things to see if I can find something. So I think that's probably the first step. Beyond that, I think the discussion is very much individual based upon what you find. Do you go investigating the embryo quality? Do you go investigating the endometrial receptivity? But I hope that helps to answer that question. It's certainly one of the most difficult areas of fertility treatment is, why are these embryos not sticking? Someone else has asked the question, is the AMH test accurate? Great question. AMH, anti-Müllerian hormone, is a hormone that is produced by the follicles from where the eggs are released. Someone's loving these. Thank you so much for the love. Really appreciate it. Hey guys, I've seen a couple of names there I recommend. Thanks so much for tuning in. I recognise. All right, so is the AMH test accurate? So anti-Müllerian hormone is a hormone produced by the follicles in the ovaries, and these follicles is where the eggs are released from. They are produced by follicles of a certain size, so the antral and preantral size. So they're when the follicles are being in the early stages of recruitment. In fact, did you know that you're germinating the follicle, unless of course you don't have any left, but you're germinating the follicles that you're going to release in an ovulatory cycle in 3 months' time. So it's what you do now that matters as to how that egg and that follicle is being affected in 3 months' time. Amazing, huh? So the AMH is being produced by these sort of small antral and preantral size follicles before they're recruited into a cycle. So technically, that hormone correlates directly with how many eggs you've got left in your ovaries. Now, about 10 years ago, when I sort of first came into this field, there was some controversy about the AMH, and what we found was that it did matter how you prepared the assay, and there was great variability, but that stuff has all been ruled out now. There is great uniformity between the labs. There is very little inter-cycle variability. It's a fairly consistent measure. It's considered to be one of the most accurate measures. The other measure, which is very accurate as well, is an antral follicle count. So that's where an experienced sonologist, someone who knows what they're looking at, is actually measuring and counting the number of antral follicles of a certain size in the ovary. Now that too is a highly accurate measure. A couple of things will affect the AMH. If you are on the pill, the oral contraceptive pill, the AMH will be falsely suppressed and it will not come back to the normal range until you've been off the pill for 3 months. It should be unaffected by the Mirena or the progesterone-containing contraceptives. The antral follicle count is really only significantly affected when you're on the pill. If you're off the pill a month, your antral follicle count will come back to normal. If I'm measuring someone's ovarian reserve using markers, I will measure the AMH off the pill. I will measure the AMH and I will measure an antral follicle count. If they kind of correlate with each other, then they're directly reflective of what the ovarian reserve is. There's one situation where I have found the AMH is probably a little falsely suppressed, and that is in girls who have hypogonadotrophic hypogonadism, where the hypothalamus is suppressed. I've talked about this before, by doing too much exercise, dieting, having a low body mass index, eating disorders, because those follicles are likely to stay really, really, really small when the cycle is shut off, kind of like when you're on the pill, and that AMH tends to be low because the follicles are those primordial size follicles. And that's the one other instance where I find that it's not truly reflective of how many eggs you have. So I'm hoping that is helpful to answer that question. Where do I use an AMH and an antral follicle count? I would use it if I am looking at someone's reproductive potential. It is not a measure of someone's fertility. It's really important that you understand that. It is not a measure of fertility. It is simply a measure of how much time you've got left. So make sure that you think about it in the right context. Thank you so much for the love. There was lots of love there. I really appreciate that. Okay. Oh, this is a good question. When should I start worrying about my fertility? I'm 37. I'm worried. What signs, red flags do I look for and what can be done? So, here's the generic answer. I don't want to talk to any one person on this, but here's the generic answer. We were born with a set number of eggs, us women, that we're ever going to have. Some of us were blessed with a good number. Some of us were not so blessed. And the way we measure that is using the AMH or the antral follicle count to test our ovarian reserve. As we age, those eggs decline in number. In fact, we're born with about 1 million. By the time we hit our first menstrual cycle, we've only got about 300,000 left. We only have 500 menstrual cycles in our entire life, and yet they all run out by the time we're 50. Average age of menopause 50, some much earlier. So you do the maths on that. There's a shed load of them that are lost, no matter whether you're on the pill, no matter whether you're pregnant, no matter whether you have menstrual cycles every month, we are constantly losing our eggs. So we have an issue with quantity. We also have an issue with quality. because those eggs have been with us since we were 20 weeks in our mum's tummy, and they have been in a state of suspension. And so the working mechanisms within an egg age as we age. And so far, science has not figured out how to rejuvenate that yet. I swear, when I do, I'll be a millionaire. But so we have an issue with quantity and quality as we age. There are studies that have been done on big populations of women who do not take any contraception. So they've looked at natural decline in fertility. We know that natural decline in fertility starts from the early 30s. It really starts to drop off by about 35. And once we hit 37, you're over the precipice. I'm sorry. We know that a woman's fertility halves every year after the age of 37. We also know that exponentially, our chances of miscarriage go up too. Why? Because the vast majority of our eggs are chromosomally abnormal, that quality thing. Does it mean you can't fall pregnant after 37? No, of course not. You could go out and have a one-night stand and fall pregnant like that. Does it mean you can't fall pregnant after the age of 45? No, it doesn't mean that at all. But the odds of conceiving after the age of 45 are about 1 in 200. So you do the percentage on that. So it matters that we age. There is no medication, natural herbal remedy that I can give you or anyone else can give you that has conclusively been proven to stop the aging process of our eggs. There just isn't. The only thing we can do is freeze them, because we know the vitrification process, the process of egg freezing, allows those eggs to be frozen in time so that they will then behave, even if you thaw them out later, they will then behave as if they were the same age that they were frozen at, which is incredible. It gives us that reproductive autonomy. So Miss 37, should you be worried? No, don't be worried. Should you think about doing something about it? Yeah, I probably would. So I'd encourage you to get along to your doctor and have a chat about what your options are. If you're in a position in life right now, you've met Mr. Wonderful, maybe even Mr. Average, whoever it is, and you're in a position to try to conceive, we want you to try for 6 months. If you try for 6 months to conceive and then you do not fall pregnant, I would strongly recommend that you go and seek some assistance and some advice about how to help you conceive, because we're not worried about that first baby at 37 because they're lots of fun. We're worried about the one that you're going to want in a couple of years' time when you're about 40, and that's when it really starts to matter. Okay. Is it common for... This is a delicate question, this one. Is it common for GPs to be ill-informed about fertility and place additional pressure on women? Oh, that's a bit of a loaded question. How do I answer that one? Okay. General practitioners are brilliant. You know why? Because they know a lot about a lot of different things. Fertility is a very specific, or infertility is a very specific area of medicine. So if you want to talk to someone about your fertility, you want to see a fertility specialist. You don't necessarily want to see a general practitioner. When would you go and see a fertility specialist? If you're concerned about your ability to fall pregnant. There are some GPs out there who've done extra training in the area of fertility, and kudos to them. Definitely, start by having a chat with someone who might have done a diploma in women's health. They've done some sort of extra masters in reproductive medicine, but really, if you want to have a chat with someone about your fertility, you've got to see a fertility specialist. That's the reality. And in my mind, you want to see someone who has done a lot of work in this area. And so there are different levels of training when it comes to fertility. Someone like myself who's done a special extra certificate in reproductive endocrinology and infertility, or someone who might have done an extra year of their training hanging out in a fertility unit. Maybe they've done a master's in reproductive medicine. So you want to see someone who has extra training in this area because it's a specialty area. So just ask to be referred. The second part of this question is a bit hard. Place additional pressure on women. I guess it's how you interpret the information. I think that women should have reproductive choice and autonomy. And we're in a position, we're in an age where we can have reproductive autonomy, whether we choose to have a baby now, later or never. That is our choice. And so if you've had the opportunity to express that and discuss that, ask your questions and see someone who has an understanding about how fertility treatments work, fertility preservations work, and you are comfortable that you are completely informed, then I think that that's appropriate. So I'm hoping in a roundabout, very politically correct way, I have answered that question. Hard to answer when I don't know the specifics. All right, I had 2 questions here on anti-sperm antibodies. This is great. There's some good male stuff in here. All right, so here's the amazing thing. Sperm have exactly half the number of chromosomes than you have, well, not you, your husband or your partner has, in every other cell in the body. So essentially, it's foreign material. The body's immune system would go, wait a second, that doesn't have the right number of chromosomes, that's foreign. And so there's a reason why the testis is completely separate from the rest of the body. In fact, the little growing sperm, they are completely separate from a man's blood supply for that reason. But there are situations where that can be breached. It can be breached if a man has, say, a vasectomy, perhaps they have an operation to bring their testis down that might interrupt the blood supply. Perhaps they have had major trauma. They've, been kicked in the testis and had major trauma and ended up in hospital. Maybe they've had to have an operation. So there are times when the blood-testis barrier can be breached. And at that time, the blood, which contains all our immune factors, gets exposed to these sperm and go, oh, these are actually foreign, and sets up an immune response, and antibodies are produced. And those antibodies can attach to the head of the sperm, to the mid-piece of the sperm, which is the powerhouse of the sperm, or even the tail of the sperm, and can impact on the ability of that sperm to move, so affect its motility, but potentially also affect its ability to fertilize an egg. So we have a problem here. If you have a sperm sample where there is more than 50% of the sperm have antibodies attached somewhere, that is considered to be a subfertile sperm sample. And the only way to overcome that is with ICSI treatment, which is a form of IVF. If it's greater than 50%. If it's less than 50%, there is an increased chance of spontaneous conception. Now, can a man with close on 100% of sperm having antibodies attached fall spontaneously pregnant with a woman? Absolutely. Absolutely. Because you only need one, and the one that reaches it may not have antibodies on it. And that's great. But the chances are pretty low, right? The odds are pretty low. So you'd have to have a lot of ejaculations over a lot of time, at the right time, in the right place, with all of the universal magic for that to actually happen. And if you want more than one baby, it's got to happen a few times. So realistically, a man with greater than 50% anti-sperm antibodies attached to the sperm is highly unlikely to fall spontaneously pregnant. And we would always recommend ICSI treatment, which is a form of IVF to conceive. But that's the whole reason why ICSI was even developed, for exactly this purpose. So I think that hopefully that answers 2 questions. Will the levels remain the same forever, or do they change over time? They very rarely change because it's an ongoing autoimmune reaction. Well, it's not autoimmune, it's an ongoing immune reaction to something that is deemed as abnormal. And it's very unlikely that the antibody levels drop to a significant level to change from a subfertile to a fertile sample. Okay, how is the egg retrieval process affected when endometriosis has caused the bowel and or ovaries to stick to the uterus? Oh, good question. Makes it really hard. Of course, there are individual scenarios in this, and that's why it's always really important to get a tertiary level ultrasound where the sonologist will comment, can the ovaries be accessed in order for an egg collection to occur? Remembering, of course, that in an IVF cycle, the ovaries start at about that size and end up at about that size. So they're so much bigger and easier to access. But if you've got a big loop of bowel that is stuck between the ovary and the top of the vagina where the needle goes through, the chances of getting a bowel injury are pretty reasonable. So we always move very carefully in this process. We always get a good quality ultrasound to see if a transvaginal egg collection is even possible. And then we have a discussion with our patients. So there's a risk of damage. There's also a risk of decreased access. And sometimes if the balance is in favor of doing the egg collection over doing surgery to normalize the pelvic anatomy, then it may be that you compromise the number of eggs that you get. Is there a specific time frame to start IVF again once you've stopped breastfeeding? Do you have to have your cycle back for a few months and that it's pretty normal? Okay, my blanket statement to everybody on this one is we really want you to have ceased breastfeeding completely. Not even a night feed, not even a little snuggle, huggy feed with baby. And the reason why is that the hormones will affect endometrial receptivity. So we want you to have at least one normal, if not two normal cycles before we start you on a fresh IVF cycle or even a frozen embryo transfer. So hopefully that's fine. Why do some women with PCOS not ovulate on Letrozole? Oh, great question. So Letrozole is an aromatase inhibitor. It stops the conversion of androgens. Now here's the amazing thing. Androgens are actually produced from the cells within the follicle and is converted to estrogen, which is then released to grow the linings so that when you release an egg and it's fertilized, the little embryo can actually stick in the endometrium. So aromatase is the enzyme that causes that conversion of androgens to estrogen. So therefore an aromatase inhibitor stops that conversion. And when you don't convert to estrogen, that feeds back to the brain to say, oh, there's not much estrogen here. And the brain kicks in to start an ovulatory process. Isn't it fascinating? Isn't it amazing how we can make someone ovulate? But why would someone not respond? Well, firstly, the dose could be too low. So we give you the option, we give you a couple of options to increase the dosage. But if someone's not responding to an aromatase inhibitor, I will always go back and look at the individual scenario. Because there could be other hormones that are stopping the ovulatory process. And often in the case of PCOS, it is high levels of insulin, hyperinsulinemia, which is common in women with PCOS, that drives androgens, and the androgens feedback, they have their own feedback loop, particularly if they're high, to then further suppress the ovulatory cycle. So in women who don't ovulate on Letrozole, I will often go back to the lifestyle discussion. I'll often go back to the weight loss discussion. I will often go back to the diet and exercise discussion and even the introduction of metformin if they're not on it already. So metformin, which is an insulin sensitizer, is hugely important in this process, particularly in the context of someone who's not ovulating on an ovulation induction agent. And if it's not successful, after all of those things, I'll move them on to a different agent, probably recombinant FSH. So I just bypass the process and give them the FSH myself. Right, I think that's reached the end of the questions. I'm really hoping that you guys had some value in the answers to some of those questions. If you know of somebody that would really value, please tag them into this or share this, this live with as many women as you can. Remember, my mission is to empower women with knowledge to help them along their fertility journey. Thank you so much for the love. I really, really appreciate it. Next Wednesday night, we're going to look at after the embryo transfer. What are those burning questions that you have wanted to ask when you put your pants back on and you're standing there with the embryologist and the nurse and the doctor? I've already had some questions come through, but what do you want to ask when you get your pants back on? What's your one burning question? Save it up, come online next Wednesday night, and let's look at those burning questions after the embryo transfer. Have a beautiful night, everybody. Remember, everything tonight is really generic. If you have more questions, make sure you go back to your fertility doctor, back to your GP. Come and see one of us. We're passionate about what we do, and we're here to help you as much as we can. See you soon.